So I introduced myself very briefly before. My name is Suzanne Atkinson. I'm an ER physician in Pittsburgh, Pennsylvania. I started my career in medicine long before going to medical school. I'll tell you a little bit about that in a few moments. I have worked in several different ERs in the city of Pittsburgh, and I'm also currently doing some medical command work, which means that I'm in a command center where pre-hospital personnel can call me. Paramedics and EMTs in the field are helicopters that are out transporting patients, flight nurses, flight medics, and also airline pilots and stewardesses can call me for medical advice when I do those shifts. So I've done a lot of different things in the field of medicine. But I consider this whole field to be what initiated my interest in medicine. Let's get rid of that. So about 9 months ago, I was working a shift in the emergency room, and I got a phone call from a fellow physician named Mark Meyer, and he said, Suzanne, Richie's on his way in. I said, all right, cool. I haven't seen Richie in a long time. Mark is a family practice physician that works he works literally right across the street from the emergency room. And Richie is one of our homeless clients that goes way back. Mark I think he got a phone call from Richie, or somebody who was with Richie had called. I don't remember the circumstances, but Richie had a medical problem. Mark listened to the problem on the phone. He couldn't get anyone out on the street to see Richie, and he thought that this needed to be seen right away. He thought that this was an emergency. Certainly as a family practice physician who's been working with the homeless for 15 plus years, aware of all the clinics, he wouldn't have referred Richie to the ER if he didn't think he needed something really that we couldn't address there, or that only we couldn't address. So I eagerly awaited Richie's arrival, and as soon as he showed up in the ER, I immediately put my name on our electronic patient board because I wanted to be the one to see him for a number of reasons, which I'll get into in a few minutes. Not only because I was being selfish, because I happen to like Richie a lot. So that was about 9 months ago. I started this, my own personal path, in 1996. This is a poor homeless individual. If you can't tell what that is, this is a figure made of rocks. He's basically made of a rock and some accessories around that. This is a mountaineering trip that I took in 1996, which really was a pivotal point in my path to becoming a physician. And I think throughout this talk, you'll hear me refer to relationships frequently. Jim talked earlier about grafting the relationship by introducing the caseworkers to the homeless people, and we talked about this with Jen's presentation as well, developing community by introducing people. It's all about relationships on a one-to-one level or on a community level. So real quick trip down my memory lane. I met Jim in preparation for a trip to El Pico de Orizaba, which is a volcano in Mexico. It's the highest Mexican volcano. It's the third highest peak in North America. Denali in Alaska. There's a second peak in Canada, and then this is the third highest peak. At this point, I'd never considered becoming a physician. I was an outdoor educator. I taught rock climbing and kayaking classes, and I worked in retail, worked for Outward Bound, took people on trips. So I was sort of doing a helping hand, but I was helping sort of rich Midwestern youth at risk go on very expensive Outward Bound trips. And we were doing a lot of good, but it was a very specific population I was working with. I enjoyed the work a lot, but I felt like there should have been more. Right at this turning point in my life, I met these two gentlemen. That's Jim on the left. Jim on the left in the red, and this is Mark Meyer, who called me about 9 months ago. This picture was taken on that trip in 1996. And when I look at these pictures now, I was just a baby back then. That's me in the middle. I don't know, I look like my 9-year-old nephew. I wasn't 9, I was 26 or 27 in this picture. But this is a picture of our team, our literal team. Chris Lemley, who you've seen pictures of already today, Mark Meyer, myself, Jim Withers. Jim, myself, and Mark were on the same rope team together, and that's how I met Jim. He was my rope team leader. Mark Meyer I've mentioned, and this is Barb Homestek. She is still involved. I want this picture. Okay. I offered you this picture earlier today. This is the first time that I had met this guy or this lady, and now I cannot imagine my life without them. So again, this is all about building relationships. That's me. I just look so young. Tell me I still look like that. Do I? Yeah, thank you. So after that trip, just a quick note about this, because it's significant for me and it's part of who I am, so I want to share it with you. And I've got plenty of time to cover my topic. On this trip, I was an outward bound instructor. I worked in retail for an outfitter that sold backpacking, climbing, kayaking equipment. I went on this trip because I was really excited about climbing this mountain. I'd wanted to climb this mountain for about 3 or 4 years. And all the people that I knew that were going to do this mountain, I met them, they came into the shop, I would give them all kinds of expedition advice. And I'm not a very big person. And all these guys are like young, strong, 20-year-old, military guys are real like, rah, 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 we're going to run up the mountain. And I didn't want to go on the trip with them. I just didn't think it would be a good experience for me. But I waited patiently, and a mutual friend of ours named Rick Huggins, I should have a picture of him in here, some pictures on my computer. Rick Huggins at the time was 39 or 40 years old. He had quite a number of years of experience mountaineering. He had been teaching in the mountaineering school, like Jim had mentioned before, and I knew Rick from the store. I knew that he had tons of experience. I'd been on day trips with him. I had a relationship with Rick in terms of knowing his skills and his approach to all this dangerous mountaineering stuff. And I knew that he was a good person to go climb the mountain with. So I had this mindset that I was going to go and teach these people about expeditioning. When in reality, I learned that they had an awful lot to teach me about other things that were available in life. I didn't include a group picture here, but throughout this 2-week trip, each of these individuals was somehow involved in homeless care in one way or another. They were either doctors, nurses, caseworkers. Rick was a carpenter. He was on the board of directors for Miriam's, which is a shelter for mentally ill homeless women in Pittsburgh. And the whole purpose of the trip, maybe the excuse for going on the trip, was to raise money for Miriam's. It was a capital fundraising expedition. And that's why these people were going on the trip. So over the 2-week period, I learned that you can still go and climb mountains and also be involved in helping people in some way. And so I was at this transition point in my life where I had been working at Outward Bound. It was very satisfying, but it was contract work. Every summer I was moving across the country, and it became very unsettling. I wanted something a little bit more stable, and that's when I met these guys. And it changed my life. So I got back from that trip. I called Jim the next day, which was Easter Sunday, I think. They go out on Monday nights for rounds, and I said, Jim, I think you probably know why I'm calling you. And he says, oh yeah, I will stop by your house and I'll pick up those souvenirs I put in your suitcase that you brought back for me from the trip. I'm like, no, that's not why I'm calling you. I'd like to come out and volunteer with you. And so the very next night I started my volunteering with Operation Safety Net. So these are just a handful of pictures I took with an old-fashioned film camera. I had it 1600 speed film, set at 3200 speed on the camera, and then I had the lab double expose it, or expose it for twice as long. So I ended up with these really cool, no flash required, grainy black and white images, and a handful of them turned out really well. So this was my first experience with street medicine. That's Jim on the left. Do you remember who that is on the right? Luke? Lou, yeah, it's Lou. Yeah.
He slept by the river and he kept saying, I'm going to stay here until the river tells me what I really need to hear.
Neat. And eventually, I met Richie. Richie had a very interesting story. He's very engaging. He's got his little sign over here. It's got flow charts, and there's some politics. And he probably had a new one of these every day, if not multiple times a day. Really intelligent. I believe he was a pharmacist, and he had his schizophrenic break. Most people have their schizophrenic break when they're in their 20s, so they really haven't established a career yet, and they're very young in their establishment of adult relationships. Richie had his schizophrenic break when he was in his 40s, so he had an established career. He was very intelligent. He had other adult relationships, and so he has a very unique way of engaging with people. But so I met Richie in 1996, and got a phone call about him just a couple months ago, which was the most recent time that I saw him. That's him. There's another picture of him. And Mike, who you've heard a couple times, this is Jim's founding partner with Operation Safety Net.
That's
You don't recognize him, do you? Without his feathers and cape. Okay. So the topic that I'm addressing for today is use of the emergency room and emergency resources by homeless people. Who uses it? How often do they use it? Why are they using it? If you don't have experience in the emergency room, I want to take you very briefly through what happens in the ER, sort of a step-by-step, what the patient goes through. And then a case study, which is not from Pittsburgh, it's actually from San Diego, and some of you may be familiar with it. So who uses the ER? These data are taken from some papers. There's a handful of nice epidemiologic papers published in the recent literature. I don't have the references here, but I can give them to you if you like. Plus, each group probably has their own set of local data. But they look at, who's using it, how often are they using it. This particular paper was case controlled to look at how much more often homeless people and marginally sheltered people were using it compared to their, age and health match case controls. So big reasons why they may use them. It may be their only source of medical care. They may not have access to clinics. There probably are not street medicine teams in their area. They don't have insurance. They don't have a primary care doctor. It may be the only place that they go to for care. And we see plenty of this, and I'm sure that every emergency room sees a lot of it, even if patients are not homeless. The homeless people in this particular study were 3 times more likely to use the emergency room at least once a year compared to the controls. And of those that used it, there was more trauma, they had worse health, and there's generally higher morbidity among that population. Those were all risk factors for using the emergency room. Lack of health insurance, I mentioned. Lack of transportation. Maybe they can take a bus or walk to the ER, but they can't make it to the clinic that's on the other side of the river that they've heard about. Lack of communication. They don't know how to get a hold of somebody. They don't have the quarter that Jim used to hand out, or they don't have the 800 number with them, but they know where the emergency room is. The mental illness, drug and alcohol use, inner city residents, those were all risk factors for people making higher use of the emergency rooms. So this is from a separate study that looked at a total of 2,500 homeless as well as marginally housed individuals, and this is from San Francisco. This is the utilization of the ER, how many visits they had during a 1-year period of time. So the majority of the people in this study had 0 visits, 60% of the patients. Of the remaining, 8% had 4 or more visits during that 12-month period. That's a significant amount. That's more than most people go to see their primary care doctor. Once a year you could kind of see. And then you have to imagine, why are they going to the emergency room where they have to have a problem? So these are not primary care issues typically. Of these 3 parts of the pie here, the ones that actually did go to the ER, this is how many visits they had. I don't have the actual numbers up here, but of those who went 4 or more times to the ER, they consumed 54% of the total visits. So if you go back to the previous slide, there's only 8% of this cohort that were in the emergency room 4 or more times that year. And that made up 54% of the visits. So there's a small number of people taking up a large number of the visits. I'll let you look at that for a little bit. So the 60% here, these are the people who never went to the emergency room. That's why there's no red in this pie chart. Of the next groups, 19% went once in that 12-month period, and they made up 17% of the visits. 14% went 2 or 3 times. They made up almost a third of the visits. And 8% went 4 more times, and they made up more than half the visits. So these are frequent users. In your communities and in your programs, if you can identify these people and try to intervene in some way, you're going to save dollars. That's maybe the last thing on our minds. But when you're trying to incorporate emergency services in your county, police in your county, the hospital administrators, those dollars become very important. Okay. Any questions about this so far, or comments? Okay. Yes?
In your research or in the literature, did it say about the mortality of that high user group? So I would also suspect that they're using it 4 times or more, and then they're dying, like, the morbidity and mortality.
I don't remember that being a specific feature of that study. It may be in there, but I'm sure there are a lot of other papers that look at it.
That's one of the criteria for the vulnerability index for who's at risk of dying in the next 6 months.
And that's
It's on Common Ground's website. Yeah. It was done by Stephen Huang and Jim O'Connell in Boston.
Yeah, Jim O'Connell. And Jim O'Connell, Boston Healthcare for the Homeless, right?
Yeah.
There are some other papers of his that are published. If you do a brief search on PubMed, his name will come up. And I believe that the papers that are up there do address some of that, one of your questions. So the scope of this talk cannot encompass all the medical emergencies you'll see. We'll just talk about why people are using the emergency room. And as street health caregivers, what you might see and when is it appropriate to go to the ER as opposed to trying to make follow-ups. A lot of this is common sense. If it looks like it needs to be treated right now and you don't have the resources with what you've got in front of you, it may merit a visit to the emergency room. Then you get into issues of, trust. Jennifer, talked about how long it took her to get this guy to seek medical care because she wouldn't accept a cup of coffee for a year. So just because you want this person to go, they may not go. So it's not always going to be the case where you see an emergency and you're going to be able to get this person taken care of right away.
Did you send them with, this is something I wanted to ask earlier, so in each of the places that's doing this type of work, do you send them with the referral from the street?
Actually, I'm going to talk about that. Okay. Yeah. But if I don't address it, bring it up again. So this is just an overview of the big groups of reasons why people go. I think there's one more. Psychiatric issues, and these are not people that we're referring. This refers to the group of people that are going to the emergency room on their own, the homeless and marginally housed people that seek emergency care on their own. Infectious causes, skin problems. By toxic, I'm referring to drug and alcohol use, overdose, problems from drug use. Psychiatric things, depression, schizophrenia, loneliness. I don't think that's necessarily a psychiatric problem, but I can't neatly lump it into anything else. Dental problem, tooth infections, dental pain, and trauma. We had talked about that earlier. And I'm just real quickly going to go through some of these. And again, I don't have the time to get into depth about every one of these, but things to think about. Cold exposure and hypothermia. Even though you may not have snow in the winter here, if any, you still do get some cooler nighttime temperatures. And it's very easy to develop hypothermia if you are immobile, if you're not moving, if you're sleeping on a cold sidewalk, if your clothes are wet. It rains in San Francisco for sure. So hypothermia and cold exposures are a big concern. Jim showed some pictures earlier of frostbite and what can happen as a result of that. In Pittsburgh, we have a cold weather shelter that Jim could answer some more specific questions on. But in the wintertime, at least in the emergency room where I was working, we had the phone numbers posted for referrals to the cold shelter for when we were ready to discharge patients. I just lumped together metabolic and medical problems here, usually untreated chronic disease conditions. This group of patients from the study, they were self-reported HIV and TB, so they have published some numbers on this, but these aren't necessarily tested. Most of the time, people don't generally go around saying I have HIV if they don't have it. But complications of HIV and TB, complications of diabetes, cardiac and stroke. Mimi mentioned earlier hypertensive issues. These are both related. One thing we see occasionally in the emergency room is, what do you do with a homeless person? They're complaining of chest pain. We certainly have housed people who have no mental illnesses that have all the resources in the world that make frequent flyer trips for chest pain. And you have to assess that. And if you're on the street with someone who's complaining of chest pain, you have to kind of take it seriously. They do have heart disease. They do have ongoing untreated medical conditions. So when you're on the street, how do you make the determination, well, they're complaining of chest pain. Do I need to take them in right now? Can they wait? Can I have them see the doctor tomorrow? It's really hard. The conservative answer is take everyone to the ER, but we're not talking about normal conservative situations. We're talking about a population that can be distrusting and has made a history of not wanting to seek institutionalized solutions to their problems. If you think it may be a medical emergency, assess it. You've got a healthcare worker out with you. Hopefully you would be able to make a phone call to a physician who's on call for your team, and they can help make an assessment. How hard should I try to get this person to go to the emergency room? And if you decide the person needs to go, I'm going to talk in a second about who takes them, how do you get them there. This is probably the first or second most common problem that we see as well. Things that I see in the emergency room of people who come in and are homeless are just skin problems. Infections that are difficult to treat. They're not bathing well, or they're not caring for the wound very well. Jim has already mentioned foot problems and so forth. I forgot to mention why Dr. Meyer called me about Richie in the beginning. He had a big ulcer on his arm. Maybe I did mention that. And he was describing it to Dr. Meyer over the phone, and those can get bad very quickly, and you can develop a systemic infection. So he wanted him to come in and have somebody look at this ulcer. Dr. Meyer couldn't treat it over the phone without seeing it. That was the reason that he came in to see me. And we've talked about a lot of these issues, either acute intoxication, an overdose. In the emergency room setting, we frequently get patients who are brought in by EMS or police because they're unresponsive, they're found down. Maybe they're doing their usual thing and they've just had a couple of bottles of beer and are sleeping it off. But if a police officer comes across that on the street, they can't ignore it. Or they could if they wanted to, but once EMS gets involved, they pretty much have to pick up that person and bring them to the emergency room. And those are some of the things that we see. The case study I'm going to present from San Diego addresses that problem specifically. Here we go. And we talk about this very common, schizophrenia and depression are highly prevalent in the homeless population. And of that group that I presented the figures on before, a complaint of social isolation or loneliness was a major reason that they ended up in the emergency room on that day. They don't have anywhere else to go. And we see this frequently, not just in homeless people, but in people without family. On holidays, Christmas Eve, Christmas Day, they'll end up in the emergency room and you spend a lot of time with them. You're trying to sort out what the problem is, and you really don't find anything wrong. And then it finally dawns on you, oh, well, they're lonely. So give them some respect, and if you can make them feel that you care about them, that's good enough. That's what they came there for, so you've treated them. I put in a blank slide for my transitions from one topic to the next, but I'm not sure what comes next. Oh, okay, so how many of you have worked in an emergency room before? About a third of you. If you haven't worked in an ER, have you been to an ER either with a friend or a family member or a client? Yeah. Is there anyone who hasn't had an ER experience? You've never? Saturday, okay. So this will be intimately familiar to you. Quick overview of flow of emergency care. There's an identification or a self-referral to the emergency room. There's a transport to the emergency room, private vehicle, ambulance, walking, taking the bus. There's some sort of triage that happens. Every emergency room handles that a little bit differently, but at some point somebody looks at you for the first time and says, this is a serious problem, this problem can wait. The patient somehow gets to a room, either from the lobby, the waiting room in the ER, or directly from an ambulance. They're seen most of the time first by a nurse and then by a doctor, but not always. Sometimes it's in the reverse order. And then there's a disposition to be made. So where does the referral come from? It can be self-referral. People can just decide they're going to go to the emergency room because either they feel it's a genuine emergency or they don't know where else to turn. It can be a referral by someone from the street team. Any level of the street team can identify something that looks like it ought to be cared for right away. If the street team or the physician or the nurse or social worker thinks that this needs to be treated for immediately in the emergency room, you can try and transport that person. One of my early experiences volunteering with Operation Safety Net was working with, I can't remember why we took him. I didn't know anything about medicine then. I don't think it was Mikey, but it might have been. I'm thinking Mikey, but maybe not. Sorry.
Frostbite?
Yeah. In any case, there was a situation, and Jim felt strongly this person needed to go to the emergency room. And I'd happened to drive downtown that night, and my car was close to where the camp was. So we loaded him up in my little Honda Civic. I put a a blanket down on the seat.
Put a blanket in the
Yep.
car.
Put him in my car. We drove to the emergency room, and this was still before I had any exposure to medicine, so it was all really made a big impression. We walked him in. We sat down with him in the triage. At some point, we transferred his care to whoever was working in the emergency room, but it wasn't until after Jim had sat down and made sure that each healthcare worker along the way knew what was going on with this patient and why we'd brought him there. And in that situation, I believe that Jim was the admitting physician. So from an ER perspective, that's a big obstacle that we have a lot of times, depending on your local system, is do you have hospitalist admission, do you have primary care admission? If you've got a street medicine team where the physicians associated with your group have admitting privileges, that's a huge burden that's eliminated from the emergency care process. And then particular to the integrating with EMS and police, if a bystander comes across a homeless person laying on the street and doesn't think they look good and they call 911, at that point, if the person who is not looking so good is not able to very clearly and intelligently articulate, no, I don't want to go to the hospital and this is why, we're pretty much forced to take them to the hospital at that point. If a bystander wants someone to get medical attention, there is a system in place to guarantee that nobody's going to just get left on the street, hopefully. The bystander is doing what they think is right, but in some cases it may end up being a big issue, because then you get a police and ambulance and so forth when the person may not be wanting that at all. Whereas if there was a trusted group of street people, that may be a completely acceptable way for that person to get care. And then, of course, the police and EMS themselves can decide to bring someone in. You know, if an ambulance is just driving down the street and they see a guy laying there, the paramedic can hop out and say, this guy doesn't look good. Let's take him to the hospital and get him checked out. So we talked about how do you get there. I would say that if you feel someone has to go to the emergency room, the absolute best thing is to try and take them yourself. Because they trust you. You know, they've developed that relationship with you. They're not going to get all that extra attention. They don't get the authorities there. They're not going to get their name written on any sheets. They're not going to get a bill for the ambulance. It's the easiest way to get somebody there. That may not always be possible. And there may be some situations where it makes sense to call an ambulance. For example, if the person is having a legitimate medical emergency like an allergic reaction or trouble breathing or crushing chest pain, and you just don't feel comfortable putting this person in your car that looks like they're going to die any second. And sometimes police will transport. We'll get a lot of screenings before the police will take people to jail. They'll make sure this person is appropriate to be in a jail cell and that they're not going to have some medical issue in the first night there. The police don't bring them from chronic problems, but for intoxication or injuries sustained either before or during the arrest. So after they arrive, there's some sort of triage process. Somebody looks at the patient and decides what the level of care, do they need to be seen immediately or can it wait? This is a point where it's extremely important, if you can't stay with the patient for 22 hours like Jen did, it's extremely important that somebody from your team or somebody that can speak for that patient, even if it's another homeless person or another friend of this homeless person and not somebody from your team, just physically having another person there that's a set of ears to listen can be a big benefit for that patient. It can really help that patient get more out of the resources that are there. And I'm telling you this from the perspective of a physician caring for someone. If you walk into a room and there's somebody who's drunk or passed out who's not responding, you can't get any history, it's very frustrating. You end up over-ordering tests, and I don't know anything about this person. If there's somebody sitting in there, I make the assumption that this person has social skills, they have a friend, they've got somebody who cares about them, and regardless of how articulate that friend is, there's always something that they can tell the physician or the healthcare team that's going to improve their care, even if for the sole reason that it changes the mindset of the healthcare team taking care of them. And again, the theme of relationships, it sets a positive tone. It sets an expectation that this is a human, this is a person, they deserve to be taken care of. One of the reasons why I was so quick to put my name on the board with a case study I mentioned earlier is because I wanted to be sure that he got respect from the moment he walked through the door. I wanted to be the first person to see him because I knew he was walking in by himself. I knew he was probably going to smell bad. He was probably going to be dressed kind of funny. And I didn't want to have a nurse or a technician, rolling their eyes or pinching their nose or making comments about this person as the first experience of that person coming in. I wanted to be sure that the staff saw me interacting with him, treating him with respect. I gave him a hug so that they would also treat him the same way. So if you can be there with them and help set that positive tone for a good relationship with the staff, that's a big benefit as well. Again, the only reason I mentioned the evaluation by usually the nurse and then by the physician is because there's a bias that can be passed down. If the person doesn't have a liaison or if they're not well-spoken themselves, it's very easy to have these people come to the ER that get disparaged, that get criticized. And it's unfortunate. It's a sign of burnout, and they call it compassion burnout. I think there's some other names for it. What's that?
Compassion fatigue,
yeah.
secondary trauma.
Right, compassion fatigue, yeah. You'd never see a medical student or a nursing student come out of a room and say, that person is just a piece of crap, I wish they'd stop coming here. How out of character is that, to have somebody shouting you who's all enthusiastic and wants to help everybody, and then, you've probably had this experience yourself. You want to learn, and somebody says, oh, I wish this person would stop showing up, and it's just kind of a blow to the person who wants to learn. So there's a bias that gets passed along. On the other hand, if you do have interns or residents or students shadowing you, not residents, medical students shadowing you, social work students, nursing students, if that person comes out of the room and has a big smile and says, oh, this person is so interesting, if they help give the patient a personality, it really helps set a positive tone. And then at some point, if it's known that this patient's homeless, you need to get the patient either admitted, that's kind of the easier situation for the emergency room's point of view, or you need to send them out the door. If I know that someone is possibly homeless, or if I see Dr. Wither's name on the primary care listing, I can't tell you how many times I've called Jim and told him, I've got a patient of yours here. He says, really? Who is it? I've got a disposition. It's like that 1-800 number. Even if he's not going to see them the next day, at least the doctor knows that they were there. In your emergency rooms that you work in, or the ones you're trying to make connections with, it really helps to have that single person, ideally multiple people, but if there's just one social worker who is there on a full or part-time basis that can spot homeless people or that can look for the names of primary care providers that they know are involved in the care of homeless people, that person can really help smooth disposition and also smooth all those relationships that we talked about before. And then disposition, where are they going to go? Do you have a shelter? Are they going to go to a halfway house? We talked at lunch about discharging people to motels for 3 days. Who's going to pay for that? Are you sending them right back out onto the street? These are questions that are not easy to answer, and it differs with every ER, even within the same city. There's going to be a different, unique culture. And then what do you do once you get them finished with their emergency room visit? Who are they going to see next? It's nice because when I recognize that the patient is someone of Operation Safety Net, I've got a phone number that I can call. I can have them followed up on the street by an outreach team. They don't have to go back to an office. I can say, where are you staying tonight? They may or may not give me a truthful answer, but if the outreach team knows who they are and where they generally go, they can look for them on their rounds the next night or during that week. So in the case of Richie, he had this ulceration. I treated with antibiotics. I dressed the wound myself for the same reasons. I wanted the nurses to see me taking care of the wound, addressing it. Like, no, I'll take care of it. We sent him with a handful of dressings for the next couple of days. It didn't turn out to be a true medical emergency, but he definitely needed care that night. I gave him very specific instructions. We sent him home with 1 day of antibiotics, and I made a phone call to the outreach team and said, he needs more antibiotics. I don't know if he's going to get them. I'll write a prescription, but I want you to see him on the street, and if he doesn't have the prescription, can you please give him the medicines? Oh, that was the end of my Richie case study. So I'll go through a second case study in a second. Like Let's do that, because the end of the Ritchie story has kind of a funny follow-up. All right, so this is a case study in California. This is in San Diego. Dr. James Dunford is the medical champion of this, and I had some email correspondence with him about this study in preparation for this talk. This has been published in the Annals of Emergency Medicine, which is the major emergency medicine journal, so you can find more details out about this. There's also a website that describes a lot of it quite nicely. Are any of you familiar with this program, the serial inebriate program? Yeah? Have you worked with the program? You have? Okay. Do you want to come up here and present it? All right. If I go astray, feel free to correct me. All right. The interesting thing about this program is that it gets a number of stakeholders involved in the problem. I talked earlier about dollars. You and I may not care about dollars, but at some point, in order to make things happen and make significant change, you're going to have to get the dollars involved somehow. How is this going to save money? Who's going to be saving the money? How is this going to be sparing our limited resources? Until people see those numbers, until they see the cost, see what the problem is, what's the cost of the problem, and how can we fix it, you're not going to be able to get this type of incredible collaborative support. So these are 5 different services in San Diego. They're all working together. And this doesn't even include the paramedic responders and the ER physician, Dr. Dunford, who's the medical champion of this program. Just a little bit of background. Over a 3-year period, they were able to collect this information. 308 homeless people transported over 2,000 times to the emergency room. This is for, a lot of these are for chronic alcoholics. 217 patients required 652 hospital admissions. So if you do the averages, that's 3 admissions per patient. Over 3,000 inpatient days. This is in a 3-year period. So that's an awful lot of use of resources by homeless people. $17.7 million in charges during this 3-year period of time. And the hospital and the services involved only received payments for 18% of those charges. Okay, so here's a solid number that this group was able to come up with and say, this is a big problem. We think we've got some cost-saving ways to address it. They wanted to reduce the use of the emergency medicine resources, the ambulance transport, visits to the emergency rooms. They wanted to reduce the repeated use of detoxification programs for these groups of chronic alcoholics, reduce the use of jail time by intervening and helping prevent these people from getting picked up in the first place for the public intoxication. They wanted to divert these groups of people to already existing county-funded programs that were in place. So here's a program that's already being funded. Here's a whole bunch of people that could benefit from it, and there was no connection there. So how do we make that transition? Ultimately, saving taxpayers money. So this program, the Serial Inebriate Program, is for homeless chronic alcoholics who've had repeated arrests for public intoxication. They were or are eligible for this program if they've had 5 or more arrests within 30 days. So this is a significant recurring group of people. You know, I think even getting arrested once a month is a lot for public intoxication. So these people really do have significant problems in terms of arrest involvement with the police, not to mention the hospital. So the options are, progressive sentences, arrest number 1, 30 days in jail. Arrest number 2, 60 days in jail. Arrest number 3, 90 days in jail. It's not too attractive. The people that are eligible for this program also have the option of a 6-month outpatient recovery program. I'm guessing that might be where you were involved?
Ours is, we were doing housing first.
Okay.
With another agency.
Uh-huh.
They were doing case management and follow-up and things like that. And
okay.
Fortunately with them, prior to the people going, at least have access to our health team before
Yeah.
they go out. But it was just, and basically they were saying if they're chronic alcoholic and they're needing housing and stuff like that, then they would take them over to the case management and stuff.
Okay,
Yeah,
great.
First, and that would mean even programs somewhere down the line.
Mm-hmm. So there's a whole group of supportive services that were involved as well. It's not just the collaboration with the police and the judge who says, okay, you've got choice A, go to jail, choice B, go to this program. There are all these additional services that are involved. So 32% of the clients that end up going through this program complete it. There was up to a 33% reduction in the number of arrests in this group of people. Of those that completed the SIP program, they had 25% fewer arrests, which is significant. This program won a state award for reducing the use of public resources by the chronic alcoholic patients. An overall 50% reduction in the use of emergency resources. That's pretty impressive. There wasn't a number figure attached to this, but you can imagine this is significant. So again, being able to attach that number figure to it is what gives the motivation to all these different services to get involved and get connected. This is another program that I'll just mention quickly. The Resource Access Program. This is also from San Diego, and it's a paramedic-centric model where fellow EMS providers can say, "Oh, we picked up Pete again. You know, put him on your list and check and see how many times Pete has gotten picked up by the not by the police, but by the paramedics." And they'll do their best to identify what needs he has and how can we help him meet those needs so that we can stop picking him up off the street over and over and over again. Okay. This is my little art. Listening to the talks today and thinking about all these different solutions, there's really sort of a right brain and left brain approach to these problems. I was watching a video last night from TED Talks. Are you guys familiar with that? Technology, Education, and Design, I think is what TED stands for. Outstanding website. Go there. They're 10 to 20-minute talks that are just blow your socks off talks. The one I listened to last night was about right brain and left brain thinking. And as they're doing research, they're learning more and more that it's not so much of a division where language is on the left and art is on the right. Those skills and tasks are much more distributed over the whole brain. But what they are finding seem to be very distinct right and left brain issues are the way we sort of think about problems and issues. The left brain approach is very cut and dry. I can focus on A, B, C, and D. This thing has 5 parts. I can address problems 1, 2, and 3 by doing X, Y, Z. And there are times and places for those sorts of things. All of the issues we've been talking about today, it's really a right brain approach. Mimi's talk about Diva Day in the women's program. That's a right brain approach to the problem. It's not like there was a missing spot where every woman is required to have a Diva Day once a month. Like, that just doesn't exist. But what a creative solution. The serial inebriate program, having a paramedic as a central person to collect information. These are all ideas that need to come from creative people looking at the problems and identifying in a creative way what kind of solutions there are. Okay, so it's all outside the box thinking, and every one of you is going to have different experience and different solutions to the problem. If the solution doesn't already exist, you can create the solution. You can create a collaborative team to support what you think is a good solution. So it takes very creative thinking, and I think one of the unfortunate things about healthcare training in this country is that it tends to stifle the creativity out of people. Whether it's because of time, politics, reimbursement, people just get fatigued. That initial sense of enthusiasm that we had as students tends to get wrung out of us, which is unfortunate. So what did I do about Richie? I called the outreach team. Dun, dun, dun. This is the outreach team. This is Mike Sallows. This is a medical student. Mike is demonstrating how he's going to protect us. I picked this one out from that night. I had about 5 pictures that night, but he was demonstrating all of his karate moves. Mike is out on the streets almost every single night, and he knows every single homeless person in Pittsburgh. So I bypassed the 800 number, and I just called Mike directly. I said, Mike, Richard was here tonight. I gave him these medicines. I gave him these supplies. Can you please make sure that he gets seen at least in a couple of days, if not tomorrow? He says, no problem. I'll take care of it. So the funny ending to the story, that's Mike again, under one of our bridges in Pittsburgh. The funny ending to the story is that I saw Richie the very next day at a bus stop. And I was so excited to see him. I was like, Richie, how's your arm? He didn't do any of what I told him. He didn't get his prescription filled. He didn't leave the bandage on. He didn't take a shower that night. He didn't wash his arm. He did absolutely nothing of what I told him to do. And yet he showed me the wound, and it was 50% better than it was the day before. So I don't know if it was the power of magical thinking, if my one dose of antibiotics really improved him that much, or if it really didn't need treatment in the first place. But it's nice to have that kind of follow-up once in a while. And unfortunately, Mimi's not here, since everyone seems to have the picture of themselves with Dr. Mark Stinson. I just thought I'd throw this in here. Got to meet Mark a couple years ago, very shortly before he passed away. And I was very excited to meet another emergency medicine physician who was doing all these things, and I really looked forward to having a number of years of mentorship from him, and unfortunately, that didn't happen, He took us sailing on his boat, and this is one of the, I mentioned before, if you think of one of those pinnacle days of your life and what adjectives describe what you were feeling at that time, this is one of those days. And that's Mark and Jim. And that's the four of us. Jim in the back. It's me, Mimi, and Mark. So again, it's all about relationships. I think it's clear that the group that you see here today doing this presentation, we're here because we've had an existing relationship through taking care of homeless people on the streets. That's it.
Eric, quick question, actually. So this part that you're talking about, and the reason that you're talking about the interaction that homeless clients will have inside the emergency room, is that what was being referred to before as sort of the Inreach? Because this seems like this is advocacy for people actually inside of already a medical system.
Well, and I think it's a good example of how Inreach can work. My role in that particular case that I was referring to is trying to show to the other staff members that this is a patient that's worth respecting. This is a patient who is worth caring for. This patient has a personality and a life, and I know this person. And it's the same thing when you have a dedicated team in the hospital that's actually making rounds. You've got consult services for, surgery, for wound care, for psychiatry. You put in the ticketing for, the street follow-up consult service. It gives a whole new level of, my vocabulary's not working today, a whole new level of respect for that patient. So this is just one example. And the emergency room is such a critical component of care for the homeless population. How can we work together with the emergency services, police, EMS, in order to best utilize what's already available?